Hi, my name is Kendra Flores, and I'm a licensed genetic counselor at Christiana Care. I am so honored to be asked by the Delaware Breast Cancer Coalition to give an update on what's going on in hereditary genetic testing. First, I want to lay out what my goals are for this talk. I want to, of course, review the nature of hereditary cancer, as that's the basis of my talk. I want to also identify what the indications are for genetic testing. For people in the state of Delaware, what are the reasons why germline genetic testing might be indicated? I want to better understand the process of genetic counseling and then genetic testing. I want you to have a good understanding of what it would be like to get genetic counseling and if you need it. And finally, I want to explore some of the non-genetic testing ways to assess risk, because I think these are areas of growing interest and something that I think that more people ought to know about. First, let's start with the question, what is hereditary cancer? I look at it a lot like this. This pie chart here, these three parts are very important to me. First, sporadic. Sporadic cancer is the vast majority of cancers. About 65% of cancers are sporadic in nature, meaning that they happen by chance, exposure, age, environment. In essence, they happen because if we live long enough, the chance of cancer increases, and it might just happen by random fluke occurrence. And the vast majority of breast cancers fall into this category. They just simply happen by chance. Familial is an important component. It's the idea that a person who has a family history of breast cancer has a slightly higher risk of breast cancer than someone who doesn't have a family history of cancer. We know that cancers cluster in families. We know, say, having a mom or a sister who's had breast cancer increases our risk to get breast cancer. That's why we report that information to our primary care providers. When we think about familial breast cancer, it's not as simple as just environment or just genes. It's a mix of genes and environment, because we and our families don't just share our genetic traits. We share the foods we like to eat, the environment we grew up in, the house we grew up in, the ways that we behave all do tend to cluster in families. So these things can cause overlap, and it's hard to parse out what's shared environment and what's shared genetics. And of course, my bread and butter is hereditary cancer. Those are those cancers where genetics is a far larger contributing factor than the environment. These are those cancers where oftentimes a singular gene mutation being passed down from generation to generation is responsible for a dramatically increased risk of cancer. It's important to stress that what I deal in, hereditary cancer, is thankfully quite rare. Only about 10% of breast cancers will fall into this sliver of the pie chart. When I think about these different slivers of the pie chart, I want to lay them out on the scale of cancer risk. Of course, no one's going to be all the way at 0% risk of cancer, and no one's going to be at 100% risk of cancer. But if we think about this 0 to 100% scale, most people on the sporadic pie chart, the part of the pie chart, are going to fall about here. About 10 to 12% is the general population risk to develop breast cancer. So some people will be at exactly 10, some people will be at slightly above 10, slightly below, but in general, people fall on this blue bell curve. The familial bell curve looks a little bit more like this. There's less people in it, but it's wider. There are some people that overlap in the general population group, and there are some people that expand out into 20, 30% risk of breast cancer by virtue of family history alone. And when we think about the green part, the hereditary, there's really two separate mounds. We're really looking at the moderate penetrance genes. These are going to be genes that you may have heard of, like CHEK2 or ATM. These are ones where the risk is more medium, more moderate. And then there's the high penetrance genes, genes like BRCA1 and BRCA2. These are ones where the risk is much higher compared to the more moderate risk genes. But both of these are categorically higher than the general population, but it's important to point out do somewhat overlap with the familial risk as well. And when I meet with a patient for genetic counseling, I'm trying to suss out which part of these pie charts, and therefore which one of these risks of breast cancer, best estimates their chances. To simplify that further, if we think about things in the environment that we know are associated with an increased risk of cancer, say pollution or smoking, or when we think about breast cancer, estrogens, these are all things that can lead to cancer. But we have genes in our body that do nothing but stop that from happening. We're not creative with how we name things, so we call these tumor suppressor genes. And these tumor suppressor genes do exactly that. They suppress the growth of tumors. If damage starts to occur, these correct that damage in some way and stop tumors from forming. And we operate with a copy of that gene from our mom and our dad. We have two copies of every gene, a maternal copy and a paternal copy. So most people walking around have a maternal and a paternal copy of BRCA1 operating in all of the cells of their body, working properly to fight off breast cancer, to fight off ovarian cancer. Now, with time, these can break with wear and tear. Just like the brakes on your car can wear and tear, these genes can wear and tear. And so if one breaks over time, DNA damage happens, but thankfully we have our backup. But if over time that one breaks, that's where we get sporadic cancer. This long-term wear and tear on those protective genes leads to the eventual loss of their protection and the formation of a tumor. Compare that to somebody who has a hereditary cancer syndrome, someone wherein one of these copies, here shaded out, is not working, either because it's not there, it was deleted, or it's there, but it's mutated. It's not, the instructions aren't reading correctly. The instructions don't read the way they should. And thus, that person is operating with only one copy and no backup copy. It doesn't matter which parent gave them that copy, whether it was mom or dad. It's just the difference between someone walking around with one and a backup copy or someone operating just on one. Well, that one copy will continue to fight tumor progression, and over time, that one also might get damaged. And when that one gets damaged, then that person develops cancer. But breaking only one copy is more probable to happen, and it's more probable to happen earlier. That's why we see that hereditary cancers happen more often in families, and they tend to occur earlier in age. Well, you might be asking yourself the question, who needs hereditary genetic testing? Who is at risk to be in this green part of the pie chart? Well, there are two schools of thought in how to determine who does and does not need genetic testing. There's the American Society of Breast Surgeons, and they have guidelines, and then there's the National Comprehensive Cancer Network, and they have separate guidelines. The American Society of Breast Surgeons guidelines are far more straightforward. They simply state that any person who has had breast cancer may benefit from genetic testing. And this is born out of the idea that as genetic testing becomes more and more important in the treatment of breast cancer, especially later stage breast cancers, the idea of testing, the barrier to entry gets lower and lower. It becomes more and more something that we ought to consider just in case. And that's why in 2019, the American Society of Breast Surgeons recommended that every individual with breast cancer consider the option of germline genetic testing for things that could be contributing to hereditary cancer. Now, the National Comprehensive Cancer Network, or the NCCN as we call it, says that it can be considered for all. It states that anybody who's had breast cancer may want to consider this testing, but helpfully, they do provide further guidelines of when testing is more recommended. This allows us to suss out who's more likely to be positive, and if someone is on the fence about testing, we can convey who does and does not meet NCCN criteria as a way to delegate who's more or less likely to be positive. So I want to next go through what those NCCN guidelines are. What I'm about to share is the version 3 2025 version of NCCN. If you are watching a later recording of this, this may not be the most up-to-date version of NCCN. NCCN guidelines tend to change about every 6 months to a year. And because of that, what I'm describing now is accurate as of right now. First and foremost, the diagnosis of breast cancer at or under the age of 50 is a red flag for hereditary cancer. Triple negative breast cancer, so something that is ER negative, PR negative, and HER2 negative or triple negative breast cancer, is a risk factor for genetic contribution, and anyone with TNBC should consider genetic testing. Male breast cancer, while rare when it does occur, is a risk factor for hereditary cause, so all men diagnosed with breast cancer should consider the option of genetic testing. A person who has multiple primary breast cancers. So here, and I want to define multiple primary breast cancers are not breast cancer spreading to other areas, but two separate distinct occurrences of new cancer. Perhaps this could be in the left and the right breast, or perhaps this could be in two very obviously different quadrants of the breast. Not cancer that is spread from one location to the other, but two separate foci of cancer. Now, this could occur at the same time or at a later date. So this could be someone who at the time of diagnosis has, say, bilateral breast cancer, or it could be somebody who had breast cancer at one age, goes on many years, and later on develops a separate second breast cancer. That's considered a second primary breast cancer. And by virtue of having two separate cancers, think of it as two separate lightning strikes as opposed to cancer coming back. Someone who has had two separate primary cancers also qualifies to consider hereditary genetic testing. Any person with breast cancer at any age who has Ashkenazi Jewish ancestry, so Ashkenazi Jewish ancestry is ancestry from Eastern European ancestry, Jewish ancestry, should consider the option of genetic testing by virtue of the fact that individuals of this ancestry are more likely to be positive. There are 3 specific mutations within BRCA1 and BRCA2 that occur more frequently in individuals of this descent and makes the a priori or initial likelihood of finding a mutation somewhat higher. There's the blanket statement that if a doctor, especially in this case a medical oncologist, would deem genetic testing fruitful in aiding in treatment decisions. In other words, if systemic treatment is on the table and knowing whether or not a person is positive, has a mutation, could inform the use of, say, a PARP inhibitor therapy, if it would aid in that systemic treatment decision, then genetic testing is recommended. Then to get into how family history can factor in. So if you have a family history of 2 breast cancers on the same side of the family, plus your own breast cancer for a total of 3 breast cancers on the same side of the family warrants consideration of genetic testing. A breast cancer in yourself at any age, plus a breast cancer in a relative at or under the age of 50 will meet criteria. Breast cancer in yourself, plus breast cancer in any male in your family will meet criteria. If you yourself have breast cancer and you have a family history of ovarian cancer or pancreatic cancer at any age, as long as that relative is 3 steps from you on the tree, first, second, third degree relative, so as far out as, say, cousins with an ovarian or a pancreatic cancer, you also meet criteria to consider genetic testing. A high risk or metastatic prostate cancer. So prostate cancers get graded in the aggressiveness of their tumor, and they can also be metastatic. Most prostate cancers will not become metastatic, but if a prostate cancer leaves the prostate, that makes it a more aggressive tumor. And these types of prostate cancers are more likely to be hereditary in cause. So a person who has breast cancer and has a family history of this aggressive subtype of prostate cancer also warrants consideration. In cases where we don't have pathology reports for relatives, it is possible to use the idea that a male relative died of the prostate cancer, presumed to be metastatic in nature, is enough of a proxy to say a person who has a relative that died of prostate cancer and they themselves have breast cancer might want to consider genetic testing. And finally, this is a little nuanced one. If the breast cancer that the person has is lobular in subtype and they have a family history of gastric cancer, so stomach cancer, specifically diffuse stomach cancer, a special subtype of stomach cancer, then they also qualify to consider this genetic testing. Keeping in mind that that was awfully detailed, but the goal here is to say that if any of these criteria are met, the probability that we're going to find hereditary cancer increases. And the goal here is not to undertest, but in some ways overtest, because if I'm not finding about 10% of my patients are coming back positive, I might be missing people. We need to overtest people to ensure that those people that are in the 10% of the pie chart are identified, because it makes a dramatic difference to their care knowing that they have hereditary cancer. So how do we find out if we have hereditary cancer? For the most part, it occurs through the process of genetic counseling. So let's go through where genetic counseling occurs in the state of Delaware. Here on the left, you'll see in color coded here these little bullets for where the sites for in-person or telehealth genetic counseling occur in the state of Delaware. So I personally work at Christiana Care. That's the blue dot here. We have our main center at the Helen F. Graham Cancer Center in Newark, Delaware. We have a satellite clinic just over the line in Maryland at Elkton, the Union Hospital. And we have a satellite clinic down in partnership with BB Healthcare, the Tunnel Cancer Center in Rehoboth Beach, Delaware. The Bay Health Hospital has a partnership with the UPenn Telegenetics program where they offer telephonic genetic counseling to individuals in the general Dover area. And Tidal Health, the Nanticoke Cancer Center, utilizes a laboratory service to provide telephonic genetic counseling as well. These are the genetic counseling programs, but keep in mind that additionally, many surgeons, many OBGYNs, many primary care doctors do offer their patients genetic counseling in their own offices. So there are many ways that people are getting genetic testing, and this describes how people are getting genetic counseling. So when you meet with a genetic counselor like myself, you come in as yourself, as your own medical history, your own perhaps cancer diagnosis, and we first focus on you. I will always take a 3-generation pedigree, which means that I'll ask about their children, I'll ask about your brothers and your sisters, and of course, their kids, your nieces and nephews. We'll gain what information you have about your parents. Are they still alive? Have they had cancer? If they passed, what did they pass of? We'll want to learn about your maternal aunts and uncles, as well as those people's kids, your first cousins. We'll go out as far as your paternal grandparents and your maternal grandparents to get this much of an information, learning more about what people had, what kind of cancer they had, if known, how old were they? Were they in their 30s, 40s, 50s? Do we know where the cancer started, not just where it spread to? And we'll use that to transform it into a pedigree. So what you're looking at here is an example pedigree. This is my language. This is how I meet with a person. The arrow always points to the patient. Men are squares, women are circles. Women are always on the right because we're always right. The idea here is that we meet with you to get an assessment of who in the family has had cancer and what the likelihood is that we would find a mutation if there is one. When you meet with a genetic counselor, we're always going to start with establishing an agenda. This is oftentimes for many people one of the few appointments that you sit for a full hour to speak with a person about the details of their own personal and family history. So I always want to start with what to expect, where we're going to go, what we're going to do, what you should know about this appointment. Then we'll start with reviewing the medical history of the patient in front of me. If they have had cancer, we'll review what that pathology report shows. We'll review what previous, screening they underwent. Have they been doing mammograms every year prior to this diagnosis? Have they been doing breast MRIs? How compliant are they with things like colonoscopies, skin checks, things like that? Then we'll take that family history in as much detail as you can provide. And I want to be realistic here. It'd be perfect if everybody had a beautiful, full, filled out family tree like I designated here in the picture, but many people don't know. And we also don't know what we don't know. So it is a perfectly acceptable answer to some of my questions to say, I don't know. My parents never told me, or we've lost contact with that relative, or that relative lives in a different country and we don't speak very often. So these are all realistic barriers to understanding family history, and we take those things into consideration when taking a family tree. Then we'll perform a risk assessment. My goal is to make sure that my understanding of the likelihood of positivity is your understanding of the likelihood of positivity. I want to make sure that if you understand my suspicion is high, that you understand that, and we make sure that your assessment matches mine, or if it doesn't, that we understand each other. In other words, if I think the probability is very, very likely that there's going to be a mutation, I want to be clear about that. And if I think the likelihood is low, I want to be clear about that as well. But in the end, it matters how you feel. Even if the likelihood is low, that doesn't mean the likelihood is no. If you are interested in genetic testing, we will then talk about the benefits, the risks, and the limitations of genetic testing. We'll talk about a couple of those here today, but there are lots of benefits to genetic testing. For example, knowing what your risk is and personalizing your treatment. In other words, if you need to start mammograms earlier, if you need to consider having your ovaries removed, if you need to consider doing your colonoscopies more often, knowing what your risk is can help tailor, more personalize your cancer screening. There are risks to genetic testing. We'll talk about some of those today, things having to do with your privacy or with your well-being. And of course, there's limitations because no genetic test is perfect. We have to be humble and acknowledge that we don't know everything. Even the most comprehensive available genetic test cannot take away a significant family history. And then, as a genetic counselor, I will promote informed decision making. What that means is I'm not going to tell you what to do. It's a very personal choice to or to not test for genetic cancer. And I want to make sure that we work together to come up with what is the best fit for you and your family. So we'll talk about the pros, the cons, and meet where you want to go. What can genetic counseling entail? Well, we need to make sure that the correct testing is ordered. Sometimes the nature of the cancers in the family, sometimes the ages of the diagnosis change the appropriate type of testing to order. Maybe something as simple as what laboratory your insurance is in network with is important to discuss so that we get the right test for you that's going to have the most reasonable cost to you. Do we have a plan for what we're going to do with the information? One of my favorite teachers always taught me that genetic testing is like picking your nose. You need to have a plan for what you're going to do when you go looking in there. So when we think about that, what are we going to do with genetic testing if it comes back positive? We need to have a plan. We don't want to do a plethora of genetic testing and then find out on the back end we weren't emotionally or mentally ready for the burden of what that information is going to show. We need to handle genetic risk that can't be mitigated. So in other words, there are some cancers, a good example of that would be pancreatic cancer, where the screening is suboptimal. That even when we are trying to find pancreatic cancer, sometimes we aren't successful in that. And that when hereditary cancers occur, they might still be very late stage at discovery. Can we emotionally and logistically handle screening, intensive, sometimes, intensive invasive screening for cancers if we're not really sure that that's going to have a return on our investment? Are the family members in your family prepared to hear this? Just because you're ready to hear this information, have you thought about what it would be like to tell this information to your siblings, to your children, perhaps? We try to explore what the plan would be to share this information if it were to come back positive. And if you are perhaps not the person in the family who has had cancer, perhaps you're coming in because of a family history of cancer, have we explored the idea that you might not be the best person for us to start genetic testing in? What I mean by that is when we do genetic testing, if there is, say, an aunt who's had breast cancer and would do this testing first and do a comprehensive test and find the mutation if there is one, then we can do something called targeted testing on that aunt's nieces, nephews, sisters, brothers. And that sort of targeted testing can be very informative, meaning we know what the cause of the family is, we know that the aunt was positive, and thankfully you've come back negative for the mutation that's causing the cancer in your family. Whenever possible, we'd like to do targeted testing. So we'll always explore if that's an option in a family. We'll also talk about the idea that testing can come back ambiguous. What I mean by that is this notion of a variant of uncertain or unknown significance. We shorten those to VUSs. VUSs are like a tree that could fall to one side of the fence or the other. In other words, we are full of variation. That variation is what gave some people blue eyes versus brown eyes. There are variations from Asia versus Africa. These variations aren't mutations. They're how ancestry sort of testing works. They follow along in different populations and they serve as markers for different genetic ancestry. But keep in mind that not all differences are harmful. In fact, most genetic differences are not harmful at all. So until we have enough information to determine, is this a mutation or is this just a marker for Irish ancestry, we call it a variant of uncertain significance. And that's sort of a placeholder result until more research can be done. That additional research could look like testing other family members in your own family. Maybe it could look like testing other people across the country. Maybe it'll look like a research study that is currently being conducted and the results will come out later. Maybe it's just a matter of technology improving. But variants of uncertain significance can be a difficult thing to swallow at first because it's not quite a yes and it's not quite a no. And we need to discuss the idea that if you need definitive answers, you need to be aware that sometimes genetic testing doesn't come back definitively. And especially for those individuals that are coming in because of a family history of cancer, we need to discuss genetic privacy. There is a very important law called GINA, which stands for the Genetic Information Non-Discrimination Act. It's a law, a federal law, that says that a health insurance company and an employer, with some exceptions, cannot use genetic information to discriminate against a person. A person can't have their health insurance find out that they're more likely to develop cancer and have that information used to raise their insurance premiums. Promotions or firings at employers can't be dictated by genetic information. Things like the military or very small employers with less than 15 employees, those are some exceptions to that employer rule. But in general, we need to make sure people are aware that genetic information has some pretty solid protections when it comes to health insurance and employment. However, things like life insurance, long-term care, long-term disability insurances, these are extra insurances. Some people have them, some people don't. Some people want them, some people don't want them. But in essence, these types of insurances can and do ask information about genetic testing. They're allowed to ask a person signing up for a life insurance policy, have you had genetic testing? If so, please share a copy of those results before we decide on what to charge you for a life insurance policy. So it can be important for individuals that are considering genetic testing to make sure that they have all those ducks in a row first. Make sure that they have the policies that they want in hand before they go through with genetic testing that could really drastically increase the cost of these insurance policies, or in some cases make them ineligible. I also want to take a brief moment to acknowledge that everything I just talked about was a lot, even in English. Could you imagine how much that would be if English was your second language? In-person, or in some cases telephonic language services or interpreter services are available. I know for a fact that Christiana Care, we have both iPad-based, so like a FaceTime-based platform, as well as in-person interpreters. And I know that those types of services are available at BB and Bay Health and Tidal Health as well. So these types of conversations occur if English is not your first language, in conjunction with a skilled language service interpreter who will be able to make sure that these nuanced conversations are understood. This is a one-time thing, right? This seems like a lot. Hopefully I only have to go through that once, right? No. For most people, genetic testing may improve. The joke I tend to make is, it's like an iPhone. There's a new one every year. And it seems like if you had genetic testing and you had, back in the early 2000s, just BRCA1 and BRCA2, it seemed like that was it. That was all you needed to know about. But nowadays, there are several different panels. Some of these panels include some rare tumors. Some of them include leukemias. Some of them include kidney cancer. Some of them don't include these. Some of them are really only focused on the highest risk genes. These are all very nuanced differences between these tests. And I want to acknowledge these are not the only test out there, but these are some major ones. They're very, very nuanced. They're very niche to genetic counseling, genetic testing, and speaking with a genetics professional, someone who is well versed in hereditary genetic testing, can ensure the correct test is done on you. And if testing has been done already, they can ensure that if there is additional genetic testing that you need to have done, that genetic specialist can talk about the pros and the cons of doing more testing. What do I mean by that? I always tell my patients, let's be pen pals. The idea here is that you're with time going to learn more information, and I'm with time going to learn more information. And periodically, we should check in with one another, make sure we're on the same page. So for you as the patient, you have to ask yourself, has my medical history changed? Did that colonoscopy come back with far more polyps than I expected it to? Has my family history changed? Did another family member develop cancer since the last time I spoke with genetics? Maybe that was a rare cancer that might change what sort of testing is appropriate. Has anybody else in my family gotten testing? Maybe I came back negative, but my cousin came back positive. Should I contact my genetic counselor again and let them know that my cousin came back positive? Yes, absolutely. For the genetic counselor side, I might ask myself, have more genes been discovered since this person got testing? If they only had BRCA1 and BRCA2, there are several additional genes associated with breast cancer that have been discovered since they were tested. Has the technology that the testing was run on changed? Over the last 20, 30 years, the way that we analyze genes has changed dramatically. And even the way that we might test BRCA1 and BRCA2 themselves has changed. So if you got genetic testing for BRCA1 and BRCA2 in the early 2000s, we can reanalyze those genes alone and find mutations that previous testing may have missed. And if you had ambiguous testing when you were first tested, perhaps when you got tested the first time, a variant of uncertain significance was seen. It's important to periodically check up on that VUS. Not only what does the laboratory that did your testing, but what do all laboratories call that? Genetic counselors have platforms to check the status of not just one laboratory, but multiple laboratories call in a variant. So when we check in periodically, I can take a look at not only what does lab A, but what does lab B, C, D, and E call that variant to make sure that no one is calling it harmful, to make sure that there isn't anything important that you and your family need to know. This is why I ask my patients to check in with me periodically. I would say every 2 to 3 years, it's a good idea to shoot your genetic counselor an email or give them a call. Maybe your genetic counselor isn't here anymore. Call the Department of Genetics and find one that is. There are lots and lots of changes, and it's important to just make sure that even if it's a quick phone call or an email, that you stay up to date. But what about people on that red sliver of the pie chart? Everything I've talked about thus far was focusing in on this green one. Let's take a moment to give justice to this red part of the pie chart, because it's important to realize that only 10% of people with breast cancer will get a clear explanation. Only 10% of people will get a genetic testing result that explains why they got cancer, but a far larger number of people have a concerning family history that isn't explained by current available genetic testing. What is available for people in the red part of the pie chart? I think about this visual here. So let me orient you. On the left is the risk of cancer. So here at the bottom is a lower risk of breast cancer, and here at the top is a higher risk of breast cancer. On the bottom axis here, more common genetic differences and more rare genetic differences. So up here in color, these are the heavy hitters. These are the ones you may have heard of as being either high or moderate penetrance genes. Things like BRCA1 or BRCA2, TP53, which causes a very rare but very penetrant or very severe hereditary cancer syndrome called Li-Fraumeni syndrome. These are the heavy hitters. And some people got testing for only these heavy hitting genes. These are the more moderate penetrance genes. The distinction between them is a little bit controversial, but think about these as the more medium risk genes, the ones that maybe somewhat affect your risk, but are not potentially the full, complete picture. They somewhat change risk and they're important to know about, but that increase might be in the 20s or 30s, not all the way up to the 80s in the percent risk. It's important to acknowledge these little dots here. These little things that on their own are not mutations. In fact, many people call them SNPs or single nucleotide polymorphisms. These are differences that just having one of these does not make or break your risk. If the general population risk is 10 to 12, having just one of these broken might put you at 13. Not enough to change things. But what if you have 7 of these, whereas the average person only has 1 or 2? Well, those SNPs working in conjunction could ultimately make you at a higher risk of breast cancer. And we believe that these individual non-mutation markers are working in conjunction and explaining that red sliver of the pie chart. That people in the red sliver of the pie chart, perhaps they share environment with their family, but perhaps there's individual minute genetic differences that are working in concert with one another, with the environment, to make a woman whose mom has had breast cancer at a slightly higher risk than a woman whose mom has not had breast cancer. How do we qualify these minutia? Well, that brings me to Olivia Munn. And I think that everybody at this point has heard that Angelina Jolie did a great service to genetic testing, and many credit her as bringing awareness to hereditary cancer. I think one day we will look back and credit Olivia Munn as a person who rose awareness to familial breast cancer. Let me read from you an excerpt from her Instagram. In February of 2023, in an effort to be proactive about my health, I took a genetic test that checks you for 90 different genetic cancer genes. She began, I tested negative for all, including BRCA, the most well-known breast cancer gene. My sister Sarah had tested negative as well. We called each other and high-fived over the phone. That same winter, I also had a normal mammogram. 2 months later, I was diagnosed with breast cancer, she continued. In the past 10 months, I have had 4 surgeries, so many days spent in bed, I can't even count, and I have learned more about cancer treatment, and hormones than I ever could have imagined. Olivia Munn is in the red part of the pie chart. She has familial cancer, and she advocates that her surgeon, there, the person that she's hugging, saved her life by doing a test called the Tyrer-Cuzick model. The Tyrer-Cuzick model is a great tool for people that are in the red part of the pie chart, people that might fall anywhere along this bell curve. And what's useful about the Tyrer-Cuzick model is it can quantify your remaining lifetime risk to develop breast cancer, both in the next 5 years and over the rest of your life. And it can be used to determine if you're over 20%. We had to draw a line in the sand somewhere, and that line was drawn at 20%. Individuals that are at 20% lifetime risk to develop breast cancer or higher are deemed high risk, and individuals that are high risk of breast cancer may benefit from increased screening. The Tyrer-Cuzick model is an algorithm. It's a computer program. It asks the person questions, and using the answers to those questions can calculate the likelihood of cancer. These questions include things like, how old are you? How tall are you? How much do you weigh? How old were you when you had your first period? How old were you when you had your first child? Have you ever had a previous biopsy that showed a precancerous finding? Some of the details of this model are questions that the average patient might not readily know the answer to. For example, your mammographic density. Mammographic density is a way that a mammogram can measure how hard your mammogram is to read, how much of that fibrous, sort of the milk-making sort of tissue is present in the breast, the part of the breast that's harder to mammogram, versus how much of the breast is fat, easier to mammogram, much easier to visualize through. Even for women that have larger breast or smaller breast, those are separate of their density. And the only way to know your density is to have that measured on your mammogram. So many mammogram reports now will actually state as a scale, perhaps there's different, you'll see there's the Volpara, the BI-RADS, different ways to measure how dense the breast is. And that information is contained in the report of the mammogram. Then the Tyrer-Cuzick takes a very detailed family history. Not only does it ask questions about who in the family has had cancer, but it also asks questions about how many women are in the family that did not have breast cancer. And that's an important distinction because a woman that has a family history that contains one aunt with breast cancer versus a woman who has one of 7 aunts with breast cancer would obviously have a different risk to develop breast cancer. So this is a sophisticated model that can ask questions about how many cancers of how many women, making it to what age. A grandma that died at a very young age of childbirth didn't live long enough to develop most types of breast cancer, so she doesn't count as much towards risk. This model can even take into consideration whether or not the person has taken hormone replacement therapy, if they're currently taking hormone replacement therapy, how long they plan to take hormone replacement therapy. And it graphs it out on a model like this, where in this case, the red line is the patient and the blue line is the general population. So you can compare your estimated risk to develop breast cancer with the risk of the general population. And if that lifetime remaining risk of breast cancer is estimated at 20% or above, most insurance companies will see that as a reason to pay for not just mammograms, as is typical for women over the age of 40, but breast MRIs as well. When a person is deemed high risk, they might be followed in a high-risk clinic wherein a provider will coordinate mammograms alternating with breast MRI. Perhaps mammograms are your winter thing and MRIs are your summer thing. So every 6 months, you would get one image or the other. Between these 2 images, you would get 2 different modalities, 2 different ways to check the breast. That is much more likely, in some cases, with these 2 working in concert, to catch earlier, much more treatable breast cancers. So it's important to acknowledge that just because someone might be BRCA or even panel negative doesn't mean they go back to general population risk. Especially those women that have significant family histories of cancer should be the squeaky wheel that asks for the grease. They should ask their OBGYNs, primary care doctors, even at many mammogram centers in Delaware, run Tyrer-Cuzick models and put them in the embedding of the mammogram report. And it's important to know what that number is and to keep in mind that breast MRIs are a very sensitive tool, perhaps inappropriate for people that don't have a high enough risk of breast cancer because breast MRIs can see things that aren't really cancer, leading to unnecessary anxiety and unnecessary biopsies, painful biopsies that we don't want to put you through unless these risks do justify that means to the end. So Keeping an idea what that risk is, knowing if you're above 20, knowing that your Tyrer-Cuzick model changes with time as you get older, as family histories change. It's important to know what your risk is and to act accordingly. I want to thank you all so much for your time and listening to me. I'm looking very much forward to the live audio where I can answer questions. And if you are not comfortable sharing a question directly, I want to take an opportunity to share my email here. If you have any questions that you feel more privately that you want to ask me regarding genetics, I welcome that contact. Thank you again to the Delaware Breast Cancer Coalition for asking me to speak and for making this time. Thanks.